Hi, everyone, and welcome to the Leong Center Trainee Hub. My name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Center for Healthy Children, as well as your moderator for the series. I'm incredibly excited to introduce both of our speakers for today's session. We're joined by Dr. Nicola McCleary, who's a scientist here at the Child Health Evaluated Sciences program within the SickKids RI, as well as an assistant professor in the Institute of Health Policy Management and Evaluation at the University of Toronto. As an implementation scientist, her work focuses on identifying effective ways to support the uptake of health evidence to improve health outcomes, including implementation of evidence-based practices and the de-implementation of ineffective practices. We're also joined by our second speaker, Dr. Guillaume Fontaine, who's an assistant professor of implementation science at the Ingram School of Nursing at McGill University, as well as a principal investigator at the Center for Clinical Epidemiology at Lady Davis Institute for Medical Research. He also serves on the advisory committee of Knowledge Translation Canada. So today's session will provide you with an overview of various models, theories, and frameworks that are used within implementation science and how they can guide the design, the execution, and the evaluation of implementation projects, which is a relatively new topic for our series to cover, and of course, of interest to those who are joining us today. So I'm going to pass it over to our first speaker, Nicola, to get us started.
Thanks so much, Priscilla. I'll just start by sharing my slides. Okay, you can see those. Okay,
Yes, we can.
good stuff. Okay, thanks everyone for being here today. I see the numbers are going up and up in terms of the attendees, so very exciting to talk to you all today about implementation science. So what I'm going to try and do in my part of the session today is give you a bit of a concise introduction. Might be a bit of a whirlwind because there's lots of different sort of concepts and theories and frameworks in here. But I'm really happy to share the slides afterwards, so you can read them further to get into further references or access some of the different resources that are mentioned throughout. So just before we start, I just want to take a moment just to acknowledge today that in Toronto here, I'm on the traditional unceded land of the Huron-Wendat and the Petun First Nations, also the Seneca and the Mississaugas of the Credit, and just to pay my respects to the now many and diverse First Nations, Inuit and Métis people for who Toronto is home today. So today's learning objectives, we're going to summarise the need for implementation science and get into a bit of detail around some of the fundamental concepts and different methods that we use. And then in Guillaume's part of the presentation, we'll discuss how to meaningfully engage community partners in implementation research. So before we get started, I'm interested to hear from you all a little bit about just your kind of background knowledge and experiences within implementation science. So I'm wondering, how would you describe your current level of knowledge in implementation science? So this is my first time using this kind of poll, so hopefully it works. So you can just scan the QR code there on the slide, or if you go to slido.com, you can type in that number and then you should be presented with the question to answer. Okay, some responses already. Let's see. So we have most people, looks like, still a few responses coming in. About 70% beginner, so just starting to learn about implementation science, and then some intermediate, so some people have some understanding and application maybe in this area. Okay, so this is great news for me in terms of some of the content I'm covering today that will just give you a bit more of that sort of introduction to some of the more fundamental concepts. So why do we need implementation science and what actually is it and what is it all about? So I thought I'd just start off with this brief story that really illustrates the need for implementation science. So this is from a researcher published in a psychiatry journal, in which he talks about research that he has led around developing treatments and supports for people who have bipolar disorder. So he said we mounted an RCT across 11 sites. We were testing specifically the chronic care model for bipolar disorder, found significant positive impacts of this model. There was no increased cost to the system. Another trial at the same time had similar outcomes, both published in the same year in sort of journals that are like well respected and highly read by clinicians and so on. And then the model was then endorsed within national guidelines and within national clinical guidelines. So here we have a clearly effective treatment, also cost effective, was widely disseminated. Of course, it should be automatically and immediately taken up. But unfortunately, that's not what actually happened. So he goes on to say that within a year of the end of these studies, none of the sites in the trials had incorporated this model into their usual workflow. The clinicians went back to what they were doing before, and so the patients were then receiving their usual form of care, which was substandard in comparison to this new model of care. So he finishes by asking, everything went right in these trials, what went wrong? So the experience in this story is unfortunately not unique. So we know that establishing effectiveness of something doesn't guarantee then that it's going to be taken up in practice. And there could be a whole range of different reasons for this. So what implementation scientists do then is investigate those reasons and then use those insights to design interventions to support that uptake in practice, to ultimately try and increase the chances that people actually get the care that they deserve and that we know will work to actually help them. So just to put some numbers there to me saying that, this is a common issue. So we know from studies of healthcare quality that about 30 to 40% of people don't receive care according to current scientific evidence, and that about 20 to 25% of the care that is provided is either not required or potentially is causing harm where, the risks might outweigh the benefits of the treatment. And in Canada specifically, we know that about 30% of care that is received by people in Canada is inappropriate. So these gaps, is important to emphasize, these gaps in care are not there because there's a lack of motivation in healthcare to improve. Obviously that's far from the case. As many of you will know, people who get into healthcare tend to be really highly motivated. They want to provide the highest quality care possible. But change in complex environments like healthcare is really hard. There's often lots of different factors which make it hard to change. And just to briefly illustrate this point, I've just included this framework that synthesizes qualitative studies that explored why diagnostic tests are often ordered when they might not be clinically necessary, which is quite a common problem. So the researchers organise these reasons into these three broad groups. So the first group are intrapersonal. So for example, some overtesting occurs because clinicians have a strong sense of medical obligation to do something for their patients, or because of some ingrained cognitive biases, which we all have, which impact how we assess risks and benefits. And then the next group of factors are interpersonal. So in some cases, overtesting is driven by the strong desire to maintain a positive doctor-patient relationship, or by perceived pressure from senior colleagues in the team, for example. And then the final group of factors relate to the environment or the context. So some overtesting is protocol driven, or might be due to time constraints within consultations, or because of the ease of access to a range of different tests. So issues like this are not unique to overtesting. We often find that similar issues like this come up regardless of the quality issue that we might be investigating. So we can start to see how implementation science evolved as a field if we think about how healthcare organisations might have traditionally approached this type of problem of there being gaps in quality of care and the limitations of some of these more traditional approaches. So traditional approaches to trying to close these gaps have often focused on better availability and better presentation of evidence by identifying and synthesizing and then disseminating that evidence in practical and more accessible formats such as evidence-based clinical guidelines. Now, of course, guidelines are really important and are a really great place to start in terms of supporting practice change, but they're generally speaking not sufficient on their own to lead to change in practice. So this point is illustrated quite well by early work of Cabana and colleagues in the 90s, who they did a review of studies which assessed barriers to physicians' adherence to clinical guidelines. And you can see here they found lots of different barriers, things like awareness of the guidelines, or even maybe lack of agreement with some of the recommendations in the guidelines, difficulty breaking current sort of habits and clinical routines that might differ from guideline recommendations, or sometimes an inability to reconcile very specific guideline recommendations with patient preferences. And then the second traditional approach to trying to close evidence practice gaps is to use what's termed the Islagiat model. So this was a term that was developed by Dr. Martin Eccles, who was one of the founders of the field of implementation science, and he was commenting on his years of experience and reviews of the literature in terms of trying to change healthcare practice. So he termed this developed this term, the Islagiat model. Not sure if anyone will have heard of it. Sounds very sophisticated, but basically stands for, it seemed like a good idea at the time. So what often happens in healthcare contexts is perhaps an evidence practice gap is identified. A group of people get together to brainstorm some solutions. Someone decides the solution that should be tested, oftentimes might be the most sort of influential person in the room. That solution then is implemented, and then we hope that it works. And this goes back to the point I made earlier. People in healthcare generally really want to deliver high quality care, really motivated to fix quality problems, and often jump immediately to solutions before we sort of fully understand the problem. So you're all, already at this point well trained in sort of scientific thinking. So I'm sure you're already thinking there's a few different problems with this Islagiat type of approach. So it doesn't draw or build on what we already know in terms of the evidence base for interventions. It's often based on assumptions about what the barriers to change might be. For example, people lack knowledge, so we just need to tell them about something. And a lot of the time it just comes down to an inefficient use of scarce resources that are available for these types of projects, so ultimately amounting to quite an expensive version of trial and error. So if we want to improve implementation, then we need to move beyond these traditional approaches to more of an implementation science approach. So kind of a fundamental sort of concept in implementation science is that before jumping to solutions, we need to understand the problem in more depth so that we can develop a more targeted solution. So we have these pervasive gaps between what we know in terms of what works to help people with specific health conditions and then what we do in terms of the healthcare that people receive. So ultimately, the work that's done in implementation science is all about developing generalizable knowledge on how to close those no-do gaps. And so more formally then, implementation science is defined as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. It involves the study of determinants, processes, and outcomes of implementation, as well as the study of methods for promoting the uptake of evidence. And the ultimate goal then is to develop generalizable, empirical, and theoretical basis on which to optimize implementation activities to ultimately improve healthcare. So we've got lots of different research activities that happen within implementation science, and I've included just a few examples here. So this includes assessment of barriers to and enablers of implementation in specific contexts, development and evaluation of implementation interventions designed to overcome those barriers, and then evidence synthesis work to try and identify common barriers to change across contexts or establish effectiveness of implementation interventions more broadly. And implementation scientists also do a lot of work to develop the theories and methods that we then use to conduct our empirical work. So implementation scientists focus on a lot of different sort of clinical topics and areas and do work that focuses on supporting implementation of evidence-informed care, but then also de-implementation of low-value care or procedures or practices that are not required anymore or where maybe the risks outweigh the benefits. And we use a whole range of different methods, do qualitative work, surveys, observations of practice, as well as things like randomized trials to evaluate interventions. And then the field increasingly getting an increasing number of speciality dedicated journals to implementation science. So one perspective that can be useful for understanding and trying to solve evidence practice gaps is to consider the gap in the context of behaviour change. And so full disclosure here, I have to say I'm trained as a psychologist, so this is the framing that I bring to my implementation work, but it's not necessarily the only framing that you can bring. So we can think about clinical practice as being composed of sets of behaviours. So these are things that clinical providers physically do as part of their role. It includes things like monitoring specific clinical markers, for example, or prescribing medications or other forms of treatment and management approaches, documentation of specific actions taken, as well as more general communication behaviours that really help build that therapeutic alliance with patients. So if we think of terms of behaviours, then we can think of solving an implementation problem, whether it be, uptake of a guideline or stopping a practice, as supporting people to change their behaviour. And, usually this will be more than one person, it's more than one maybe interlinked behaviour. And it might involve behaviour of different actors or people within the system, so not just healthcare professionals, but perhaps those in leadership and management positions too. So if we use this line of thinking, then we can draw on that evidence base in psychology about what influences behaviour and effective ways of changing behaviour to support the development of our implementation strategies. Okay, so that was a bit of an introduction to just implementation science and what it is. And now I'm going to go through just some more key concepts and things we do and ways of working within implementation science. So theories, models, and frameworks are pretty fundamental to implementation science. So get yourself ready. Hopefully this is not too overwhelming, but I'm going to introduce quite a few of these different theories, models, and frameworks to you today. So this paper here by Per Nilsson is really helpful in terms of giving some structure to the numerous different types of theories, models, and frameworks that are available. So he organised them essentially based on their purpose. So we have process models that can help guide the process of doing an implementation project. Then we have frameworks and theories that are used to help understand barriers to change or what underlying factors might be linked to implementation outcomes that we need to target with interventions. And then finally, there are a set of frameworks that help guide the evaluation of an eventual implementation intervention that is developed. So before we get into some specifics of theories, models, and frameworks, I'm interested in whether any of you have heard of specific implementation science theories, models, or frameworks. Is there any you've heard of already? Is there any you've perhaps used in your research, or maybe you've seen others presenting on use, for example? TDF, yeah, that's a theoretical domains framework. That's a really commonly used one. Any others, I wonder? Knowledge to action framework, yeah. EPIS, yes. Yeah, those are all really well established and commonly used one. COMBI, CIFAR, yeah. We're getting a few more coming through now. REAIM framework. Okay, you guys know lots of these frameworks and models already. That's great. One person still typing. Oh, CIFAR 2.0, yes, of course. So there was the original CIFAR and then it was recently updated. Okay, CIFAR. A few people mentioning CIFAR, so maybe that's one that's commonly been used in the group. Okay, great. So yeah, these are all pretty well established, commonly used theories, models, and frameworks with all slightly different purposes. So for example, your knowledge to action is a process framework, whereas something like TDF and CIFAR specifically are used to assess barriers to change. And we're going to cover not all of these today, but a few of them. Okay, so an early step then in an implementation project is often to select your overarching process model to guide the steps to develop an implementation intervention. So the one I'm going to introduce to you today is the French four-step implementation framework. And you'll see here on the right-hand side, I've also included some other tools and frameworks and different methods that can be then incorporated into each stage. Of course, this is by no means, an exhaustive list of all the different frameworks and tools available, but I just wanted to give you a sense of some of these. So the four steps then in the French process model are, firstly, to identify who needs to do what differently to close the evidence practice gap, to then assess which barriers and enablers need to be addressed to close that gap. Then once you've done that, to pick and select which intervention components might be used to overcome these barriers and perhaps enhance the enablers. And then finally, to develop an evaluation plan and think through how can any resulting change based on this implementation intervention be measured or understood. So I'm now going to give just a high-level overview of each stage and the tools associated with those. So in step one, we're specifying the behaviour change needed to reduce the gap. So it's probably likely most of the time that multiple behaviours are playing a role in the chain of events that are leading to an evidence practice gap occurring. So knowing this information up front can be really useful with helping select the behaviours that you want to target for change in terms of those which are really central to bringing about the desired improvement outcomes. So when you're doing this behaviour specification, it's really about thinking through who needs to do what differently, when and where to close this evidence practice gap. So it involves some work to think through the different aspects of this. So in terms of your who, there might be, is it multiple types of healthcare professionals that are involved? Is it a specific group of professionals? Are leadership playing a key role? What is it that they need to do differently? Are you looking to improve prescribing behaviours or perhaps advice given to patients? In terms of leadership, is it about providing more resources or enacting specific policies that would help reduce evidence practice gaps? And what's the direction of change? So are people being asked to do something completely new, do something more that they already do or less, or perhaps to stop something entirely or replace something with something else? When should this be done? Is it something that's done every day with certain patient groups during every shift? And where does it take place? Does it take place in the consultation room with patients? Is it something that's done before or after, or does the action maybe differ dependent on the setting? So once we've thought these things through and then selected a target behaviour to focus on, then it's really important to specify it clearly. So we can do this using the ACT framework. So this was published in 2019 based on some foundational work in psychology on how to clearly specify behaviours. So this can be used to describe that specific action, so the behaviour that needs to change, the actor, so the person who does that behaviour, context, so that's the physical or social setting in which the behaviour takes place, the target, so that's the people with or for whom the action is performed, so that might be a patient group, for example, and the time, so when does it happen? So I've just included an example here from a paper where we described how implementation science methods can be used to support reductions in overuse of diagnostic tests. So we just gave an example of 3 interrelated behaviours that could be targeted for change. So the actual ordering of tests by physicians and nurses, the requesting of test results by senior physicians, which puts pressure on those orderers to order the unnecessary tests, and then the setting of test ordering policy by clinical leadership, which can encourage more judicious use of tests. So specifying the behaviours in this really precise way can just help ensure you've got clarity in your team and everyone involved in a project on what we're actually focusing on and trying to change. It can help inform a bit more focused assessment of your barriers to change and selecting specific change strategies. And it can also help you identify key metrics that you want to measure in terms of evaluating behaviour change and then evaluating the ultimate success of your intervention. So once you've specified your behaviours to target for change, then the next step involves identifying what barriers and enablers need to be addressed to support change in those behaviours. And again, there's different theories and frameworks that can be used to do that. So again, another question for you all before we jump into barriers assessment. I'm interested in what are your thoughts on what you would see as some of the big barriers that might get in the way of implementing a new evidence-based practice in healthcare, or perhaps de-implementing outdated practices. So in the real world of healthcare, what might be some challenges and things that sort of get in the way of trying to bring in new interventions or take away older, outdated ones. Okay, some people are typing. Buy-in from champions. Yeah. Champions, so people that are highly respected within an organization. Their views on something can often be really influential in terms of whether something's taken up. Oh, lots of things are coming in now. Resources, yeah, is there adequate resources and funding? Muscle memory habit, yeah, that's really a really important one, particularly around sort of stopping or de-implementing things. A lot of healthcare practice is driven as, highly routinized. Time constraints, lack of knowledge, lack of skills, yeah. Role confusion, yeah, it's another one that often can be an issue. Alignment with values, yeah. And sort of values and sort of clinical professional identity, that comes out a lot. Training, lack of knowledge, yeah. Yeah, we do see these things come through, and you can see here there's a whole range of possible, just based on your guys' thoughts, there's a whole range of different barriers that can prevent change that we want to explore. Okay, so I'm going to just introduce you briefly to a couple of frameworks that can help with sort of identifying and sort of systematically organising information about your identified barriers and enablers. So the first one is the TDF, which a few of you mentioned that you're a bit familiar with already. So this was specifically developed to help implementation researchers use behaviour change approaches. So it's basically a synthesis of lots of different psychology theories into these 14 domains that cover key factors that influence behaviour change. So it's designed to help understand what providers think about what helps and hinders them in doing a behaviour. And there's a really useful guide that's been published on how to use the TDF. It provides this 7-step process, going all the way from selecting and specifying your behaviours, which we already talked about, all through, selecting your design. So you might want to do a quantitative survey, for example, to explore barriers in your specific target population, or perhaps qualitative work such as focus groups or interviews is more appropriate. Also helps you develop materials, sort of collect and analyse your data and report your findings. So this is a really useful resource if you're thinking about using the TDF. And again, just going back to this paper I mentioned where we talked about reducing overuse of diagnostic tests. I'm not going to go through all these, but we just provided some barriers, example barriers to change map to TDF domains. So for example, things like, clinicians talk about not having been trained and discussing harms and downstream impacts of over-testing with patients. So we map that to an issue with skills. And then oftentimes clinicians, order tests they know a senior supervising colleague might ask for the results of. So that maps to then the social influences that are operating within the clinical team, for example. And then oftentimes clinicians might believe that the risk of not ordering the test might actually outweigh any of the benefits there. So then this maps to the beliefs about what are their beliefs about the consequences of ordering or not ordering that specific test. Okay, so the second framework then that's often used to look at barriers and enablers is the CFER. So this one synthesizes 48 factors into 5 different domains. So the domains being the innovation itself that's being introduced, the process of implementing that innovation, the individuals who are involved, The inner setting, so for example, that could be the hospital department or maybe the organisation as a whole, and then the outer setting. So for example, that could be, the province, and then the associated aspects of how healthcare is governed within that province. So the CFIR then is designed to support collection of data from people who have power or influence over implementation outcomes. So that could be, but might not always necessarily be the same as the specific people who are being targeted for change. So the CFIR then has also some useful kind of resources and supports out there for its use. So it's got this website that's got good resources in terms of, how to structure a interview topic guide, or aspects of support for aspects of qualitative coding. Although it is in the process of being updated since, as we mentioned before, the framework itself has recently been updated, but there's still lots of useful information there. Okay, so once we've identified barriers and enablers that we need to address, then our next step, of course, is to select some intervention components that could help address those, and then develop those into a complete intervention package. And there's, again, lots of tools out there that are available to help with this. So firstly, there's a range of different taxonomies. So these are defined as formal classification systems which list and describe different change strategies. So these taxonomies really were developed as implementation scientists started to recognize that we really needed to improve the way we were describing and reporting our strategies. So, oftentimes people were using the same terminology to refer to different strategies, or different terminology to refer to essentially what was the same type of strategy. So, as you can imagine, this really hampers progress in terms of sort of sharing and then synthesizing knowledge about what works and what doesn't work. So it was recognised we needed more of a shared language to describe our intervention content, and also this more consistent description would then help us, with things like replication and evidence synthesis work and so on. So these taxonomies, you can review them, discuss potentially useful strategies as part of the intervention development process. So I'm going to just very briefly introduce three. So the first one is the epoch taxonomy. So this was developed to support categorization of implementation interventions and systematic reviews, but it's now used sort of more broadly. And this is just a sample of some of the specific strategies that are in that. So, it includes healthcare worker focus strategies like audit and feedback reports, which involve, auditing practice and sending then feedback on that audit to healthcare professionals about their practice, or educational meetings, as well as strategies that would change how care is coordinated, or perhaps who provides care in terms of role expansion or task shifting, for example. And then ERIC is another taxonomy that's been developed that includes 73 strategies. And that includes things like, changing the physical structure and equipment that's available, creating learning collaboratives, identifying and preparing champions, reminding, electronic reminder systems, for example, or revising professional roles. And this, as you can probably gather, it's got some overlap with the epoch taxonomy. For example, it also includes, audit and feedback and educational initiatives as well. And then the final one I want to introduce is the behaviour change techniques taxonomy. So this is not an implementation science specific taxonomy, but it was developed by psychologists to help with specifying behaviour change content in terms of behaviour change techniques. And if we're applying a behavioural approach in our implementation science work, it can be a really useful one to draw on. So this one then has 93 different techniques, and they're grouped into 16 broader categories. So for example, some focus on monitoring of behaviour and providing feedback. Others focus on supporting the formation of goals and sort of action plans to see through those goals, or shaping knowledge, perhaps providing social support within teams to enact changes, or encouraging self-belief, just for example. On one quick note, just with the BCT taxonomy, it's recently been further developed a part of this broader behaviour change intervention ontology project. So the BCT list has now been expanded and includes 281 BCTs now. And this team now is doing a lot of work to then link them to other aspects of interventions. For example, which setting are these techniques best to be used in, or who's best placed to deliver them, for example. So just to flag that that's there if you're interested in further reading about that. So that was the 3 taxonomies that can be used to help select your intervention strategies. And then another way that can be helpful for deciding what interventions you want to use are to look at the existing evidence base for effectiveness of these different intervention types. So there's already been lots of evaluations of different types of implementation strategies, and then this evidence then has been synthesized across systematic reviews. And due to just this sort of sheer number and varying quality out there in systematic reviews, it can be helpful to initially have a look at syntheses that have been published in the Cochrane Library. Could be a good place to start. And many of these are reviews of RCTs or cluster randomized trials. And this table here just gives just a small snapshot of some of the syntheses that have been done and the findings. So you can see that strategies such as giving healthcare providers educational materials or on-screen reminders or providing audit and feedback all have generally proven effectiveness. So we can see if we look at the end column, so the median improved performance. On average, these strategies have, smallish effects. But then if we think about, these interventions being deployed at a population level to improve care for, a whole population or panel of patients, then, these effects are potentially pretty important and impactful in terms of patient care. And then we can also see, though, from the end column that there's quite a wide variability in these effects. So, sometimes these strategies work really well, other times they don't work so well or might not work at all. So, the evidence base in implementation science is really just still evolving in terms of understanding, what explains this variability and how can we maximize the effectiveness of these different strategies. Okay, so there are also some different mapping tools that are available that can be helpful for selecting implementation strategies. These can be really particularly useful because they directly draw on the work that's done at the previous stage to identify barriers, and then they also bring in those taxonomies that I previously introduced as well. So for example, some work's been done to map the domains in the TDF to the BCT taxonomy to help identify some specific techniques that can be really useful for overcoming specific barriers. So there have been various iterations of this mapping over previous years, and this here is the most recent version. So it's presented online in a user-friendly tool known as the Theory and Techniques tool. So basically this tool has, it's a matrix approach, so it's got behavior change techniques listed, and then along the top row there is what they term mechanisms of action. So that includes your TDF domains there along the top row. And then the matrix basically includes green color coding to identify which techniques might be most likely to help overcome specific barriers, within the goals domain. For example, there's a lot of green in that column, so a lot of these techniques can be really helpful if you identify an issue around sort of goal setting, for example. So there's also been a similar matching tool developed where the CIFR, the domains in the Consolidated Framework for Implementation Research, have been mapped to strategies in the ERIC taxonomy. So again, this can really help you with identifying specific strategies that can help overcome very specific barriers. And again, here you see green links here, which indicate stronger consensus from implementation experts that a specific strategy would help to address that barrier. Okay, so that was a bit of a summary of different kind of tools and resources that are out there to help with selecting intervention components and developing your implementation intervention package. So back to our process framework then for the final step. So, once we've developed our intervention, we want to evaluate it. So this involves, planning an evaluation study, thinking through how can any resultant change in practice be measured and understood. And again, there's lots of resources that are available to help with this. So implementation interventions can be evaluated in randomized trials in the same way that clinical effectiveness interventions are. So we're very fortunate in implementation science that this group of really great implementation scientists got together and developed this guidance for how to conduct implementation trials. So there's lots of really useful information in here. So they advise that a trial of an implementation strategy is warranted when there's a healthcare or public health intervention that's supported by evidence as effective, ideally by a systematic review, and when there's also a known evidence practice gap. So this involves verifying that that intervention that's evidence-based is not being routinely implemented in practice. And also when there's equipoise or uncertainty regarding the effects of an implementation strategy or what strategy might be best. So this guidance also goes into some details about different types of trial designs that can be used. Again, I'm not going to go into this in detail. Also, I'm not a trialist myself, so I couldn't go into lots of detail and examples here. But just wanted to give an overview that it's useful in there to discuss different types of designs. So for example, it might be appropriate to do a two-arm parallel cluster trial where, you maybe randomize hospitals to your implementation intervention or a control, or you might do, a step wedge trial where everyone in your hospital, all of the hospitals, in your sample, they all receive the implementation intervention sequentially, but then the order in which they receive it is the part that's randomized. And it's also possible to do hybrid effectiveness implementation trials, and that's where you do that if you're interested in assessing both clinical effectiveness outcomes and implementation outcomes. Again, not time to really go into a lot of detail today about the different types of hybrid designs, but just wanted to flag to say that, you can read more about them in this paper, but then this paper also links out to further resources and guidance and sort of background information on those different types of trials. So the trial guidance also covers considerations for implementation trial outcomes. So implementation trials tend to focus on measuring the extent to which an intervention has achieved implementation of the evidence-based care that was being targeted, or de-implementation of the low value or non-evidence-based care. So this would include things like, measures of professional practice improvement or changes in processes of care or adherence to clinical standards, for example. And here, important to think about bringing it back to ACT, which the framework that we introduced at the very start that can be used to specify your target behaviour for change. So here, if you've specified that at the beginning, your trial outcomes, you really want those to be reflecting your targeted behaviours. So did the implementation intervention itself result in changes to the behaviours targeted? So you want to be thinking through what are some ways that we could, rigorously measure change in those behaviours. So there's lots of other types of implementation process and outcome measures that can be assessed as part of an evaluation. So these were all first sort of synthesized and listed out by Enola Proctor and colleagues. And so this paper is a really good resource for thinking through different sorts of outcome and process measures that you might want to include in the evaluation. So, for example, you might be interested in acceptability of the intervention in the target group, or perhaps it's fidelity. So that's the extent to which it was actually delivered as it was specified in your protocol, for example. And worth flagging, we do have a bit of a measurement problem in implementation science where, there's lots of development of sort of bespoke study-specific measures, and some measures that are not necessarily fully vetted in terms of their reliability and validity. And so this systematic review here that I've highlighted on the slide is really useful for providing a repository of different tools that are available for measuring these different aspects of implementation, and they evaluate these tools as well. So the final piece I just wanted to mention in relation to evaluation is the importance of process evaluation. So this is a type of study that doesn't focus on effectiveness of an intervention, but it can be done alongside a trial, and it focuses on explaining how and why an intervention might work or why it doesn't work, as is often the case. So process evaluations can focus on different things. So they can focus on assessing aspects of the context. So that's those, external factors that might influence implementation. So things like, aspects of the organizational or political environment, for example. Can focus on studying implementation or, deployment of the intervention at a specific site to help understand the processes through which it's actually delivered. Or process evaluations can also focus on understanding the mechanisms through which an intervention produces its effects. So for example, just this study here I've included on the slide, they use the TDF as a model to propose their mechanisms of effect. So they hypothesize that their specific implementation strategies would do things like improve skills or remove barriers to change, for example. So those were the mechanisms of effect that they proposed. Okay, that was all of the content I had today. I just have one slide now just to provide an overall summary of the content. So, we've seen that there's really a wealth of research demonstrating that there are pervasive evidence to practice gaps in healthcare. The goal of implementation science then is to close those gaps through scientific study of methods to promote systematic uptake of evidence in practice, ultimately to improve health outcomes. The core basis of an implementation science approach is that before, we want to avoid jumping to solutions and really take time to understand a problem in depth. There's lots of theories, models, frameworks, and taxonomies out there that can help to guide the implementation process, help to identify who needs to do what differently to close the evidence practice gap, can support your study of barriers and enablers, and then assist with selection of change strategies and techniques that are fit for purpose. And then those interventions can be rigorously evaluated through trials with accompanying process evaluations. That's it for me. I'll stop.
Amazing. Thank you so much. You've given me a lot of food for thought, which I'm sure for others on the call, similarly with respect to their works. I was jotting down so many notes, Nicola, as you were chatting about things I wanted to go back to in your presentation and go to the original articles and reread that material to immerse myself a little bit more into the frameworks and theories and how it might leap into some of the work that I'm engaging in. So
Good.
thank you very much for that. Um, I think what we'll do is take a 5-minute break for those on the call before we transition into the second presentation. For today's session, this will give everyone the opportunity to stretch their legs, perhaps grab a teas, a glass of water. So that brings us to 2:26 p.m. Eastern Time. We'll get back online and we'll resume today's session. So I'll see you all in 5 minutes. Hi, everyone, and welcome back as we settle back into this space to continue the second part of today's session. Perfect. So we will just jump right in. Gilliam, if you're able to screen share, perfect. So you're welcome to just launch into the presentation.
Great. Thank you so much. Can you hear me properly?
Yes, coming through
Okay,
clearly.
excellent. Okay, good afternoon. My name is Guillaume Fontaine. I'm an assistant professor at McGill University. I'm involved in implementation science, implementation and research in different research networks, primarily in infectious diseases. So the Canadian Network on Hepatitis C, the Canadian Network as well on HIV and STBBIs. And following Nicola's excellent presentation, I'm going to try to cover how to engage interest holders for effective implementation. And I'll clarify just now what I mean by interest holders. Um, so essentially, right, we have been using for some time now the term stakeholders when we talk about engagement. Um, but if you've seen, there was a recent paper that was published in, I think it was Cochrane Evidence Synthesis and Methods last year that talked about, moving away from the term stakeholder. And really it's been something of a public and scientific debate for some time now. Um, but I prefer now using the term interest holders instead of stakeholders as recommended by this article. Um, because stakeholder has colonial roots essentially, right? So it was really related to how people that were, coming to Canada or America were planting stakes in the ground to mark land that was to be removed from Indigenous peoples. So it's a term that can be perceived as disrespectful, exclusionary as well. So the consensus from this group from Cochrane was to use interest holders instead, really to emphasize that we're looking at engaging those responsible for and affected by health-related decisions. Um, and they define interest holders as groups with legitimate interests in the health issue under consideration arising from responsibility for or being affected by decisions informed by health research. They did consider some alternative terms that you can look up in the article, and they talk about why they didn't select some of those other terms, which is quite interesting. So I'm going to use interest holders in the context of my talk. So, like Nicola, I have a few questions for you. So first, what is the first word that comes to mind when you hear engagement? So is the slider working?
It's not working. I just tested it for myself. It's asking me to
Yeah,
sign
it's
in at the
asking
McGill.
McGill login.
Yes.
I'm so sorry. Okay, so if it's not working, maybe you can just put it in the chat and that's going to be all right as well. That's fine with you all.
Okay.
Um, so I don't know if Priscilla, you want to chime in and kind of say the words that come up in the chat.
Absolutely. We're already getting some words populating the chat, including active, involvement,
Mhm,
collaboration, participation, partners,
mhm,
collaborate,
mhm. Right.
partners, community.
Partners, community, collaboration. So collaboration is often the first one that works, that comes up. Active involvement as well. Meaningful, I
Meaningful.
like that one as well. That's a really good one. Yeah. So we want meaningful collaboration, right? And involvement. So again, okay, another question for you. When do you need to engage interest holders in your project from your experience? Always as early as possible from the beginning. I mean, ideally, right? All stages. Those are all good answers for sure. So essentially, right, we need to think about the engagement of, and sorry, I have the old term here, stakeholders still, but the promise is going to be removed from the other slides. Um, from the planning and preparation phase to the implementation phase to the sustainability and dissemination phase. And really also, even before that, from the ideation phase, and really about identifying what is the knowledge to action gap. We need to think about how do we engage different people in the identification of what needs to change, really. And those discussions need to come really early in the process in conjunction with the evidence and insights from clinical settings and community. So then why do you need to engage interest holders in a project? What are the reasons you think about? Relevance, right? Relevance to their needs and priorities, that's for sure. Transparency, meaningfulness, incorporating different perspectives into the production of knowledge. Right? We want to ensure that the knowledge and the evidence generated is relevant to the community because they're the ones that are going to be affected the most. That's true. Ownership of knowledge and evidence produced.
Mhm.
Yes, those are all excellent reasons. We can think of a few different reasons that we might want to engage uh, interest holders at different stages. Um, and first, really in the planning and preparation phase, ensuring relevance and that the research addresses real world problems and meets the needs of the community and the population that we aim to serve. They can also bring in some really novel ideas in terms of innovation and can provide critical input in terms of feasibility of your project. And the implementation phase, really looking at what is the acceptability to them in terms of the evidence-based intervention that you want to implement, but also of your approach to implementation, of your implementation strategies. They can also help you to mobilize different resources. And of course, the more you engage people, the more you're able to build trust within the community that you're aiming to serve. And then the post-implementation and dissemination phase, really their involvement is critical for sustainability, dissemination of results, and in some instances, how you influence policy and decision making. So there's a wide range of reasons why we might want to engage different interest holders. And these people can be the public, patients, their family, whole communities, uh, clinicians, service providers, community organization workers, health system managers, policymakers, decision makers, really from the community to the federal or global level, and also members of the industry. In some instances, we need to work with industry for different reasons. It might be because industry has, something to say, or something to provide in terms of resources for your intervention or the way it's going to be delivered. So a way that you can map different interest holders within an organization is often looking at organizational charts. Uh, I'm going to talk a bit more later about patient, public, and community engagement. But now if we start with those in different organizations. Um, so for example, I'm using this method called interest holder mapping for a project that I'm doing across Canada. It's aiming to look at testing and treatment for different infectious diseases. So we're using charts like this to look at within the context of an organization or ministry, uh, who is who potentially should be involved in your project, and also who has decision-making power, who might have some uh, should have a say in the implementation of your intervention. And you can use existing organizational charts that exist in relation to a hospital, a clinic, a setting, and they call it the Cosmos method. And you can then say with different methodologies, those in green, for example, are generally supportive of your intervention. Those in yellow are neutral. Those in red are opposed. And those in gray, you don't really know. And then you can also say by highlighting the boxes with different thickness, those that maybe should be engaged first, and then those that you can engage later. So that's a kind of a way to go systematically about how you engage and map those different interest holders at a high level. You can also do what we call the power interest grid. And again, this is often used in an organizational context or in the context of a specific setting to map those people that have high power and high interest in your project, those that have high power and low interest, low power, high interest, or low power, low interest. And essentially they say once you've categorized those people that you know of within the setting, for example, the hospital or the area where you want to do your project, in red, those are the people, you call them the promoters that you need to manage closely and really keep engaging really intensely. The latents you need to keep satisfied. They say the ones in the yellow box, the defenders, you need to keep informed. And then the apathetics, you need to monitor them. But I like this way of thinking because it says that if we want to, develop any given project, often we can't think about, we need to be comprehensive in identifying the people that we want to work with, but we're not always able to engage everyone to the fullest extent. But this power interest grid is quite interesting. So another question I have for you is, what is a strategy that you can use to engage interest holders at different levels? What can you do really to engage them on an ongoing basis? What types of activities, of strategies? Um, yeah. Any ideas? Communities of practice, excellent idea. Co-development meetings, yes. Co-design process, excellent. Town halls, that's great. Advisory group, excellent also. So those are all different strategies that we can use for engagement. Excellent examples. So there's different ways, right? So we could say, we're going to do uh, collecting feedback at a foundational level. And that can go from conducting surveys to doing interviews to doing focus groups with different groups of people. You can collaborate at a level higher and form advisory groups, committees, public forums, groups, coalitions even. You also have some patient-directed and mediated implementation strategies. You have interest holder-directed implementation strategies. You have approaches like integrated knowledge translation, and you can have engagement plans that are tailored to different people, and also community-based and participatory approaches. So I'm going to talk about a few of those. So if we look specifically at engaging patients and citizens, it's defined as, if you engage them in decision making, it should be really active participation in a range of activities. And we're talking about planning a project, evaluating a project, even providing care in some ways, research, training, and recruitment. And it should start from the premise of expertise by experience. And patient engagement involves collaboration and really partnership with professionals and researchers, if we're talking about citizen and patient engagement in the context of health research. We do have a number of patient-directed and mediated implementation strategies. So for example, some patient-directed interventions, health information materials, mass media campaigns, question prompts, patient decision aids, and so on. And you also have patient-mediated interventions and strategies. And those are interventions that are aiming to influence clinical practice through engagement of patients. So for example, when you distribute a prompt or a card to a patient to tell them to ask the provider about a specific health issue. So those are patient-mediated interventions. And you do have, in addition to those interventions that I showed, a number of other resources provided by Healthcare Excellence Canada on how to engage patients in research with different toolkits, how to develop different tools, mostly, from an educational perspective, and family-centered engagement as well. You also have, if you look at other types of strategies to engage interest holders, you have within the ERIC implementation strategy taxonomy a number of implementation strategies that are focusing on developing interrelationships between interest holders. And to me, this is a critical group of strategies that we should consider first and foremost when doing any implementation project. And some of those we know quite well, some other ones we might know a bit less. But of course, identifying and preparing champions, organizing different meetings, recruiting, designating, and training for leadership at different levels, informing local opinion leaders, building a coalition, obtaining commitments, identifying who are going to be the early adopters of your intervention, conducting some local consensus discussions with different clinicians and providers, using advisory boards, work groups like we discussed earlier. So it's really like an interesting resource, and you do have within the paper outlining the taxonomy a number of examples on how each of those provider level and kind of organizational level strategies for engagement and communication can be deployed. When you talk about integrated knowledge translation, we often present that in contrast with end of grant knowledge translation. So integrated knowledge translation really aims to engage knowledge users and different groups of knowledge users throughout the research process. This requires a collaborative and participatory approach to research that is action-oriented, solutions, and impact-focused. And this is in contrast with what we often did in the past, which is translating the results of the project at the end of the study. So it doesn't mean that we shouldn't do end of grant, end of project knowledge translation, but really having an integrated knowledge translation approach is a kind of a new paradigm to make sure that we engage people throughout the study. So integrated knowledge translation is a way of doing projects and research. It's collaborative, participatory, action-oriented, often community-based, and looks at really co-producing knowledge. And really it aims to integrate a range of partnerships in the context of a project. And I'm going to give you an example after just one or two slides. Really integrated knowledge translation, that means that if you have different groups of knowledge users, and you can call them, interest holders, as we called them earlier, you should work together with them to shape the research questions, interpret the study findings, and craft messaging around them, and help mobilize them to help move the research results into practice. So that's at a foundational level what integrated knowledge translation should seek to do. But if you want to go a bit further, interest holders and knowledge users at different levels, so that could be clients, service providers, managers, can help you decide on the methodology of the project, help with data collection and tools development, and help also with the dissemination and application of the findings. So really they can have a broader range of contributions beyond those first few points. So an example of that is there's a grant that I put in together looking at developing a framework to scale up testing for hepatitis C and different infectious diseases in Canada. And what I outline in my proposal is that I would be working with 4 groups of knowledge users, or you can call them interest holders. The first group were public health knowledge users, so those working in the Public Health Agency of Canada, and then also working with public health individuals at the provincial level. The second group that I had identified were people working in different community organizations and healthcare organizations, and really those providing networking for different organizations involved in infectious diseases. The third group that I had identified were research networks that were national or global in scope, and that also do advocacy to support care in this area. And the final group were citizen knowledge users. And that's the term I like to use often instead of client or patient. So I talk about citizen knowledge users. And what's the best approach is to not involve a single knowledge user, a citizen knowledge user, but really to have a group of citizen knowledge users that have lived or living experience of the disease or the condition that can work with you, because we have to be mindful about the power differentials in the project. So another question I have is, and I know that this Slido is not working, but what are the principles and values that underpin meaningful partnerships with interest holders to you, or what should be the values or principles that guide us? Trust, respect, transparency, mutual respect, equity. Yes, these are all excellent answers. So if we look, there's different guidelines for that. But really what pretty much everyone says is that we should strive for mutual learning, mutual respect, mutually agreed upon roles and responsibilities, mutual recognition of efforts, and mutual exchange of information. So really we have to think about those, the engagement process as something that goes both ways. Some of the key elements for success that have been identified, within, and this was conducted by the Canadian Institutes of Health Research a few years ago. They looked at different knowledge translation projects and looked at key success factors in engagement. And what they say is that engaging knowledge users in and throughout the research process was associated with success within those projects, but also assuring commitment and buy-in from partners, and not necessarily financial contributions, but really looking at what are the interest holders within the context of your project and engaging them from the start and securing some commitments in one way or another. So I think those two first factors speak to the importance of engaging people from the outset. Another way to think about the continuum of engagement is to look at the spectrum of engagement from the International Association for Public Participation in Research, which states that we have 5 levels of engagement. At the foundational level, we're talking about informing individuals at different levels. So informing citizens, clients, and managers and decision makers. So that really is the foundational level. It seems a bit basic, but often, I can tell you that from a number of projects that I've been involved with, often that basic level is not fully, let's say, realized. So really, we should strive to first keep people informed and really in an efficient manner. And then the second level is consulting. So that often involves, doing one-on-one discussions with different interest holders, having some group discussions to obtain feedback on your research plans or your project plan. And this is really for them to feed you with information. And then for those that want to contribute more significantly, it's really the third level that's where it starts, the involvement level. And that involves working and partnering really throughout the process to ensure that public concerns, aspirations are understood and considered. But this is meant to be across the project as well. Collaborate is essentially a deeper level of involvement. So that could be, for example, them shaping more significantly the research design, the intervention, the evaluation plan. And then empowering is the final level, and that involves putting the decision-making power into the hands of the public or the interest holders. So that's the final kind of level, the most advanced level. And I can say that it's really rare that we're involved in a project where we're truly at the empower level because more often than not, researchers have, maintained control of the project, let's say. But we really have to think about how we can do more empowerment of the public and different people. And then you also have some core values for engagement that are outlined by the SIM consortium. So I think those align with those that I discussed earlier, but they're quite interesting to look at if you want to look up at the guidelines that they have on the website. And interestingly, they also have a code of ethics for engagement, which is quite interesting. So I'm going to show you an example of how we applied, I think, pretty successfully a community engagement process. So what we did, and this was a few years ago, so I think the project was completed in 2022, I believe. And it was a project that was conducted in Ontario, across Ottawa, Peel, and Toronto. And what we sought to do was to tailor how vaccination is offered and using which strategies for different public health priority populations in Ontario. So what we did is we partnered with the public health agencies of Toronto, the region of Peel, and Ottawa to co-develop a project, really. And there's a paper that we published last year that outlines the methodology that we use for community engagement, if you want to look at that. So I'm going to show you some of the key aspects of the paper. So first, we did really a 7-phase process for the project. The first one that we started with, in this case, was aligning the goals of the research with system-level partners. So that meant that when we were elaborating the grant proposal from the outset, we worked with the Ministry of Health of Ontario and also the public health units from Ottawa, Peel, and Toronto in looking at what are the key priorities at the moment from a public health standpoint in terms of COVID-19 testing, vaccination, and care. And from the outset as well, we also had a citizen partner on the research team to help us shape those initial phases of the research. And then when we started to understand what were the priorities at the system level, we continued at this step 2 to engage with public health units to understand what are the local priorities, because often that's the case that they're going to have very different priorities for the region of Ottawa, the Peel and Toronto, right? Because of course, there are different cultural communities, cultural groups, and the epidemiology of COVID-19 can be very different for each region. So we continued the engagement process to understand more what was it looking like on the ground, essentially. Once we understood the local priorities at that level, we started to work with community leaders in each region. So that meant service providers and other individuals working in cultural organizations, faith-based organizations in Ottawa, Toronto, and Peel to understand the strengths of the community, but also how things were going on the ground a bit more, to understand what was going on for COVID in each region more specifically. And at that time, we also formed a community advisory group for each city. So we formed, and those community advisory groups were really representatives from each community that we were working with. So for example, for Toronto, those were members of Black, African, and Caribbean communities of the community and service providers that formed the community advisory group. And that in each of those regions, those groups helped us develop and establish what would be the framework for us to continue working together. What would be the engagement framework and the values and the principles that would be guiding the work that we do. Then, so at that stage, we formalized at stage 5 the partnerships with those community members really in the context of the study. And then the step 6 was about doing essentially the core objective of the study, which was to do a range of interviews across groups and across cities to understand what were the barriers and facilitators to being vaccinated for COVID in each region, but also what are the strategies and things we need to be putting in place to help people access care. So we did many interviews, and those community advisory groups helped us recruit the results. And essentially, those groups also at step 7 helped us understand the results of each region. So they really provided critical input into telling us, well, those barriers make sense, enablers make sense. These are the strategies. So they really were critical into looking at the results of the study with us in each region. And then once this was complete, they helped us draft evidence briefs that were fed back to the public health units in each region to make sure that we adjusted how care was provided for COVID. And when we, were doing the engagement process, what we really tried to do is to have a framework and following an engagement framework. So in the manuscript, you can see a detailed example of our framework, how it was set up. So essentially, we have 8 or 9, I think, themes that structure the framework. We have guiding principles within the framework as well. And then we have an example of how within the optimized platform, which was the name of the project, this is how each of those principles was translated, tangibly in the context of the study. So at a foundational level, when you do engagement, you have to think about the procedural requirements, right? You have to think about how are you going to engage, ensure sufficient and diverse representation from each region. That has to be a central consideration. You have to clarify what are going to be the roles of people that we work with. What are they going to do, essentially, right? And this has to be agreed by the people, of course, that you're working with. You have to think about, are you going to offer compensation for those people? And also make sure that the language that you use in every single communication is appropriate for them to be able to participate to the fullest extent. Then you also have to think the second theme is convenience, right? So we have to think about how do we ensure accessibility of the project meetings? Is it going to be done by, Zoom, Teams? Is it going to be in person? How are people going to be able to contribute? Some of the people that we work with have not, contributed necessarily in the context of meetings, but they contributed through email and WhatsApp and a shared online folder that they were working with. So it's really a diverse way of ensuring that people can be engaged in the research as well. So accessibility and flexibility are really critical. Then the third theme is around how do you provide constructive feedback to individuals? making sure that we explain how their feedback was shaping the project. In terms of the fourth theme, it was around fostering positive team interaction. So we identified a consistent point of contact that people could easily reach out to and obtain, information to what they wanted to, their questions. And we also made sure that we fostered as much as possible a reciprocal relationship, positive social interactions in all meetings. The fifth theme is around the research environment. So making sure that we foster a safe, trusting research environment, acknowledging power imbalances as well. And what we strove for is always having more members of the community in a meeting than researchers. So we pretty much achieved that across the board. So I think this was perceived as something positive in the process. And the last three aspects are first, support. So making sure that we have financial support for participation, but also skill-based and instructional support to make sure that people can participate fully in the study. So making sure that if you need additional information and all of that, it was provided. Second to last, making sure that people felt valued in the context of the project, considering their motivations, acknowledging contributions, creating quick and tangible wins. And then finally, at a broad level, especially at the end of the project, highlighting the benefits of engagement, and making sure that we also offer further opportunities to be engaged, because some of them, are still engaged in other projects that were started by the research team in that setting. So, in summary, engaging interest holders is crucial for the success of any implementation project, critical for relevance, feasibility, acceptability, and sustainability. They can contribute a range of resources, funding, expertise, access to networks. They can enhance the scope, the impact of your project. Establishing meaningful partnerships with interest holders is essential but difficult. But we need that to have an impact on project outcomes. And also keep in mind that we have a range of ways to engage interest holders, from really simple ways like surveys, interviews, focus groups, to more collaborative ways, to different types of patient-directed and interest holder-directed implementation strategies, to integrated knowledge translation, to community-based and participatory approaches like the one that I just showed you. So we have a range of options, and the question is which one we want to use and what works best for the given project. But I really think this is a critical aspect of any study. So thank you.
That's incredible. Thank you so much. I too, during your presentation, was jotting down notes very quickly on things that I want to go back and reconsider in building out my knowledge within this set. And also with respect to your work, reading the fuller breadth of the article and material you were sharing to immerse myself a little bit more into, where these findings come from, what are the methodological approaches, why were certain decisions made, that sort of thing. Just get a little bit more into the weeds, I think, with that respect. But thanks to both of you for coming today and sharing both your passions within this space and also some practical things to consider when we're navigating questions around implementation and with respect to our own works within the space of child health research. So at this time, I want to open up the room to questioning. For those of you who are still on the call, please feel free to either raise your virtual hand. You're welcome to unmute and ask the question you may have, or please feel free to add your questions to the chat. I'll be keeping an eye, and I'm happy to bring that question to the attention of our speakers. So I will give folks a moment to kind of reflect and collect their thoughts and decide which form they'd like to pose their question to both of you. But perhaps a question I would like to pose, just to kind of kick things off a little bit, is more around the advice piece. You both presented a lot, and for many of those on the call, this is, early days for them in acquainting themselves with implementation science, reflecting on how this could be woven into their current projects or potentially a future project that may come down the pipeline. what advice would you give to those on the call, both, trainees and perhaps those a little more progressed in their training portfolios who are looking to integrate implementation and engagement into their work for the very first time? Where should they really kind of situate some of those early thoughts and reflections and organizings of themselves to get going? So either one of you are welcome to jump in.
That's a great question. My sort of joke answer would be make friends with an
Hmm.
implementation scientist.
Yes.
Of that can help you. There are, but on a serious note, there are like lots of us out there. So there are probably, whichever institution you're at, there'll be people studying implementation. So you can start to like follow their work, sort of reach out, make connections. I know I'm always happy to chat to people who are interested in learning more about implementation science. There's a few good textbooks out there that are a good place to start. So Sharon Strauss's, um, uh, what's the title again? Knowledge to Action. I'm just looking at the book on my shelf, Knowledge to Action framework. So the book that's based around the Knowledge to Action framework. So Sharon Strauss and Ian Graham, that book's a really good place to get started. There's a few other sort of introductory texts to implementation science that are really useful. And I guess if you're, if a lot of the work you're doing is thinking about sort of developing sort of clinical effectiveness or healthcare interventions, just start to think ahead, like, if this works and we want to implement it in practice, who are the key people that we would need to engage to do that? And think about, all the reflections in Guillaume's talk around what methods could we do to start to engage them really early in the process. Because oftentimes, an intervention might be developed and there have been opportunities along the way to identify some of these issues around sort of acceptability and feasibility that you can build in to earlier stages. So starting to think through some of those aspects early on can be helpful.
That's perfect. Any additional thoughts, William, about your own work and kind of the own advice you would bestow upon trainees kind of getting started with this?
It's such a complex area, right? There's a lot, it can be overwhelming. And it feels like, at least to me, it felt like when I was just starting out that you learn a bit and then you learn that there's more and then continues to expand, which is super exciting from a scientific and academic standpoint, at least for me. So that's what I like. But I like, of course, that we have a lot of practical tools. So I would say that one of the first steps would be, Nicola's presented many different tools. I've presented some as well, like the engagement framework, for example. So those are things that exist now that you can work with. And I really think that the first step is, of course, reading up and coming to those presentations, but also, using one or two of these tools in practice, really, either to try it out, how it would work, or integrate it to your project. And I think that's the first step is to start using those tools practically to better understand them and better understand what types of results you're going to get. So for example, Nicola talked about the theoretical domains framework, right? The framework. So when you start using those tools, you get a better understanding of what results you're going to get and the implications. But really start. I mean, my own advice would be that. Yeah.
That's
I think
perfect.
that's great.
Oh,
And just, what Guillaume said made me think of a few other things. And I think, yeah, part of it is that implementation science, it's, still like a relatively young field.
mhm.
20 odd years of like kind of use of, work was going on before then, but in terms of like official use of that as a term, like for the field. So I guess a lot of people who find their way into implementation science, through different ways. So like I trained in psychology, met people who were applying psychology and implementation science, thought it was really cool, and then sort of followed on from there in further studies. But more and more now we're seeing like specific, postgraduate courses in knowledge translation and implementation science. So it's worth keeping an eye out for like courses that are available, a lot of like free courses online as well. Sign up for the the Knowledge Translation Canada newsletter that identifies lots of different sort of further training opportunities as well, and is just a way to become more integrated into the community.
I think that's a great suggestion. I was actually going to plug the Center for Implementation. I've had the opportunity to do some of their courses that they offer. The first is free, so that's always a nice place to start and building out networks with those that are already within the space. If you need to, dip your feet a little bit more into it. What I've heard from both of you also in this process of advice giving to the trainees and those on the call is this is messy. Like it is, especially for the first little while, it can be a bit of a messy space. Um, but often I like to think, especially from the engagement piece, it's not necessarily a bad thing that there's a little bit of messiness, some questions. Like I think that has a lot to do with growth in your own professional development within the space and building out in your own kind of career path within implementation science, and picking up on the tones, Nicola, of it being an early young field. That's true. Um, we often, as a community-based researcher, ask our interest holders, to be vulnerable alongside us as we're navigating these projects, that it's not a one size fits all. And I think we have to be forgiving of, some of the learnings, especially early on when we're growing our familiarity with the space of implementation or just engagement as a whole. Um, that mistakes will be made, but it's okay. Those are just opportunities for lessons to be learned and to grow from there. And I often encourage individuals who are publishing within the space to document those because that's how we learn from one another. Um, so whenever the opportunity is, I myself make sure to include, within the discussion and encourage trainees here too to publish on those specific elements when appropriate, because that's the way that we learn from one another and grow.
For sure.
Absolutely.
No, I mean, we have to be transparent about,
Yeah.
for example, when we started working with one of the community advisory boards in Toronto for the project that I was talking about, and it was the members of Black, African, and Caribbean communities, and we had to acknowledge, right, the racism, discrimination, all of the historical harms that were perpetrated against some of those communities, and that's often the starting point of some of those discussions as well, right? Acknowledging what has happened in the past and for us to have a better path forward. And those discussions are really critical in terms of building rapport and relationships with the people that we work with.
Absolutely. I'm going to
Yeah, and I
connect.
think
Oh,
it's
go ahead, Nicola.
Oh, I was just going to add, and I think as well, part of building that trust is also like researchers being open about our own like vulnerabilities and
Mhm.
worries and concerns about things, and just on that more human level. That's like a two-way process. So I think that's important too.
Absolutely. It's definitely a bi-directional relationship. Um, if we're looking to dispel the power dynamics and, call the elephant out in the room, it's incredibly important practice to build that in.
Mhm.
So I'm glad both of you highlighted that piece for those that are on the call. Did want to check in on those in the call to see if there are any questions from them in relation to today's presentation. Um, and also to let them know that if there are any questions that do arise after today's presentation and call is ended, that I'm sure they're welcome to reach out to either one of you to pose their question and continue the conversation.
Yeah, of course.
Right.
Maybe one final thing I would flag, just Priscilla, because you mentioned the Centre for Implementation. I think important for to also highlight the Centre for Implementation Research, which is a different
Yes,
place, which is the group in Ottawa that myself and Guillaume did our postdocs in, and that's probably one of maybe the most like the biggest group of implementation scientists in Canada, I think, there, and they have a website that's also got a lot of resources and sort of webinars there that drill into a bit more details around, for example, some of the frameworks that I mentioned today that, that I gave a, a few seconds overview of. They've got like whole webinars on these different frameworks, and they're doing lots of great work there around further developing, implementation science theory and methods, and it's a good group to follow for some of the sort of rigorous science behind this stuff.
Perfect. Thank you for highlighting that, Nicola. I often send out a post kind of email to those that were in attendance or couldn't make it live with additional resources, append, PowerPoint slide decks, the recording. I will highlight both for people to explore a little bit more. Okay. Well, if there aren't any additional questions in this exact moment, um, I'd like to thank both of our speakers for joining us today. And for those on the call, I just want to thank you for attending today's event. Having speakers come and discuss implementation science is certainly a first for the Trainee Hub. It's certainly not the last, where we'll continue unpacking this and building your skill set out within the space because we acknowledge that it's an incredibly important tool or familiarity to have as you continue progressing and pursuing your education and working within the space of child health research. So I certainly look forward to seeing everyone at our next event, which is next week. Please look at the Leong Center website for additional details and to sign up. I just want to wish everyone a wonderful rest of the day. Thank you.
Thanks,
Thanks, Priscilla.
Priscilla.
Thanks,
Thanks,
everyone.
everyone.
Thanks so
Bye.
much. Bye.